Good evening. Thank you for joining us for our webinar on voluntary assisted dying. What do you need to know? My name is Phoebe James and I'm a Professional Development Officer with the Hunter New England Central Coast Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the lands we are all meeting on today. I come to you from Newcastle on beautiful Awabakal land and pay my respect to elders past, present and any First Nations people joining us today. Just some housekeeping. This session is being recorded and will be available on the PHN website under the Education Library in the next few days. There will be a Q&A session at the end of the presentation, so please feel free to put your questions in the question box and we'll answer as many as we can. Before we jump to the Q&A session, we're going to hear from Sandra Fitzgerald, who is our very own Health Pathways Clinical Coordinator, and Sandra will run us through some what Health Pathways is up to and any pathways available. Today, presenting for us, we have Jeanette Lacey, who is an end-of-life care nurse practitioner and Deputy Lead for New South Wales Voluntary Assisted Dying Clinical Advisory Group. I'll now hand over to Jeanette.
Thanks very much, Phoebe. So thanks for joining us today. And today I'm going to give you a presentation with a bit of an overview on voluntary assisted dying and the Act and obligations underneath the Act. But we'll also talk a bit about what we've been doing from the Hunter New England perspective, and that's the local health district in which I work in, and how we have been working between Hunter New England and our local district in trying to ensure that we are ready for voluntary assisted dying when it comes. So many of you would be aware that the New South Wales Parliament passed Voluntary Assisted Dying Act in 2022 on the 19th of May. And that Act will allow people from the 28th of November of this year the choice to access voluntary assisted dying in New South Wales. When I talk about voluntary assisted dying, I feel like it's a really important point to make at the beginning of any of the talks that we do, that this is a subject that can be divisive. It is a subject that people have very strong feelings about, pro or against, or are sitting on the fence and don't know much about it. And I have been an end-of-life care nurse practitioner at the John Hunter Hospital for coming up to 8.5, almost 9 years now. And I've worked with literally thousands of people coming to the end of their life and have supported them and their families through the dying process. And I became involved in this process because I feel that this is a choice that people will now have on the 28th of November. Because they have that choice, because it's an end-of-life care choice, it's been my business to make sure that I understand how this Act works. And as part of doing the implementation and the rollout for Hunter New England, I felt like it was important that we produce some sort of statement that explained why we're doing the work that we're doing and why we think it's important that we have a strategic, safe, empathetic and compassionate environment in which we can support our patients. And so that's this slide. And I would like to acknowledge, you know, when I talk about this today, that there are aspects of this that are going to be difficult for people and that people might feel strongly about. But I hope that we can remember that at the centre of all of this is a person who is trying to make some very difficult decisions about their life. So in New South Wales, as you would be aware, we are the last state in Australia to have implemented voluntary assisted dying. And therefore, in some ways, we're a little bit lucky because we have got lots of data and lots of information that has gone before us, which has enabled us to try to get a bit of a picture about what this might look like for us as of the 28th of November. And Western Australia and Victoria are the only states that have actually been doing this work for more than 12 months. So they have released reports based on that. So the first couple of slides I'm going to share with you is a bit of information from those two states. So this slide here is talking about some raw data from those states that tells us about their first requests. As you can see, high numbers of first requests, but then as people go through the process, People who are eligible, the numbers drop down. People who complete all of the assessments required for voluntary assisted dying, the numbers drop down again. And then people who actually end up taking the substance, the numbers drop down again. The percentage of people who die in each state that access voluntary assisted dying has been 0.6 in Victoria, or just under 0.6 in Victoria, and 1.1% of people, 1.1% of all deaths in Western Australia. And we are working in New South Wales on a presumption of 1.1 to 1.5%, although some early evidence from some early data from Queensland tells us that it could be a little bit higher than that. But everything that we're modelling ourselves on is about 1.5% in New South Wales. You can see that in Victoria, almost 60% of people self-administer the substance for voluntary assisted dying, and in Western Australia, it's 32%. Now, there's a very good reason for that, and that is that the legislation is different in both states. In Victoria, it is presumed that all people will self-administer unless there's a very good reason that they can't. Whereas in Western Australia, the patient themselves has a choice about whether or not they want self-administration or they want self-administration, or they want practitioner administration. And again, you can see that there's a very different number there for practitioner administration of the substance. And in Victoria and Western Australia, the same as internationally, about 30% of people who go through this entire process actually end up dying without taking the substance. The average age of people in Victoria and Western Australia, and I believe Queensland, in their first 3 months is 73 years of age. The place of residence at the time of the first request is at home for 80 to 90% of people. The majority of people are English speaking. 80 to 85% of people are engaged with palliative care services. 60 to 80% of people are from metro areas, small numbers of Aboriginal and Torres Strait Islanders. The next bit of data I've got here about the time from the first request to the final assessment, there's some little stars there because this is different data and it's reported differently from both of these states. So in Victoria, the time from a first request to the final assessment for a patient, the average is 16 days. In Western Australia, they have a 9-day lockout period in which from the first request to the final assessment, the minimum time period is 9 days. 17% of people in Western Australia requested that this time period be reduced. So it's different information that we have, so you can't compare apples with apples, but it does tell us that people are trying to do this relatively quickly in the Western Australian model. 70 to 80% of people requesting this have a primary malignant disease that's making them eligible for voluntary assisted dying. 7 to 15% are neurodegenerative disease, and then you can see respiratory diseases and other non-malignant diseases are the next category down that we see. So when we look at New South Wales, the eligibility criteria for people to access voluntary assisted dying is that they must be an adult who's an Australian citizen, a permanent resident, or has been a resident in Australia for at least 3 years. They must have been living in New South Wales for at least 12 months. They must have decision-making in relation to voluntary assisted dying and be acting voluntarily without pressure or duress. They must have the ability to make and communicate their requests and decisions about voluntary assisted dying throughout the formal request process. And they must have at least one disease, illness or medical condition that is advanced, is progressive and will, on the balance of probabilities, cause their death within 6 months or within 12 months if it's a neurodegenerative disease such as motor neuron disease. And that disease must be causing the person suffering that cannot be relieved in a way that the person considers to be tolerable. Now, the people that are going to be assessing whether people are eligible for voluntary assisted dying are going to be medical practitioners. And the people who do the assessments are called coordinating or consulting practitioners. Those people must hold specialist registration, including specialist registration, of course, includes GPs, or they must have held general registration and have practiced the medical profession for at least 10 years. They must complete the approved mandatory training that has been released by the Ministry of Health. They must meet any other requirements prescribed by regulations such as AFRA to maintain their registration. They cannot be a family member of the patient, and they cannot know or believe that they're going to benefit financially or materially from the death of the patient beyond reasonable fees that you would charge your patients who are having any consultancy. There is also a role within the Act for people called administering practitioners. Now, these people, again, can be specialists. They can be medical practitioners with only 5 years of practice, or overseas trained specialists holding limited or provisional registrations, or nurse practitioners. And the decision to become one of these practitioners is an opt-in system. You must nominate if you want to do this work, and you must go through the training and go through the processes involved in that to be able to support patients who want to do voluntary assisted dying. You have to do all of those things before you are what's considered an eligible authorised practitioner. Conscientious objection is an important thing that we need to talk about because all healthcare workers can hold a conscientious objection to voluntary assisted dying, and they have the right to refuse to participate in the request and assessment process, to prescribe, supply or administer the voluntary assisted dying, or be present at the time of the administration of the voluntary assisted dying substance. However, if you are a medical practitioner who holds a conscientious objection under the Act, you still have obligations that you must fulfil. And it's also against the law for a medical practitioner to withdraw any of the services that the practitioner would normally to provide to a patient or their family because of a request for voluntary assisted dying. So conscientious objection is okay, as long as we remember that there's other obligations that the law states that must be followed regardless of that conscientious objection. Now, everything that I'm going to tell you today is available to you in almost everything, in what is called the New South Wales Voluntary Assisted Dying Clinical Practice Handbook. And this handbook was released about, I'm going to say 8 days ago or 9 days ago, and it's available. If you Google it, you will easily find, if you Google New South Wales Voluntary Assisted Dying Clinical Practice Handbook, you will find almost everything that I'm going to talk to you about today. Except of course for the stuff that I'm going to talk about at the end, which is what we've been doing to try to get prepared for that in the Hunter New England district. So let's start with discussing voluntary assisted dying, because that is an area that, that is different to other legislation around the country. So we'll start with talking about that. So if a patient raises voluntary assisted dying with any of the people that provide them with healthcare or personal care, that healthcare worker is able to provide information to the patient commensurate with their level of knowledge, or refer the patient onto a care navigator service. So that's a patient-raised discussion. If a medical practitioner would like to initiate or make a suggestion about voluntary assisted dying, they are allowed to do that under the Act in New South Wales, as long as at the same time, and during that same discussion, they also tell the patient about all the treatment options and outcomes that are available to them, and about the palliative care treatment options and outcomes that are available to them. So that's medical practitioners, they're allowed to do that. The other people who are allowed to do that in New South Wales is any healthcare worker, and a healthcare worker is anyone who provides health or personal cares to a patient. They are also allowed to initiate a discussion or make a suggestion about voluntary assisted dying if at that time, during the same conversation, they also tell the patient that they have treatment and palliative care options available to them, and that they should discuss those options with their medical practitioner. And people who initiate or make suggestions about voluntary assisted dying and don't fulfil those things that I've just outlined may find that they contravene the Health Practitioner Regulation national law, and may face, have the possibility of facing professional conduct investigations or misconduct investigations through that law. So when we have these conversations about end-of-life care, I think it's, you know, where all of you do this, I'm sure, on a regular basis. But I think it's just worth highlighting some of the resources that are available and some of the things that we should consider all the time. And I do know that everyone does this regularly, but I think it's important just to recognise that all of these conversations, if a patient comes to you and talks about it, or if you want to talk to them about it, the conversations must remain patient-centred. They must recognise the challenges and the complexities about end-of-life decision-making. There are significant complexities in this space. If patients are talking about it, we need to clarify what exactly they're asking. I guess with curiosity, that's one way I like to think about it, empathy and support, and that they will still require ongoing care. And if required, they may require services, referral to other services such as palliative and end-of-life care services, to voluntary assisted dying services, and we'll talk a bit about those pathways later, or to other mental health supports. And we will send on these slides to you, but there's some hyperlinks in here regarding some other support for talking about end-of-life conversations, such as the use of Vital Talk, end-of-life essentials, and end-of-life law for clinicians that provide some guidance around these areas as well. So I'm going to now get into a bit about the process and what the process looks like and what's been set up in New South Wales for this. This diagram is taken directly from the clinical handbook, so it's very busy, but we're going to talk about each step as we go through. But it gives you initially an overview of what happens in voluntary assisted dying. There's a first request, a first assessment, a consulting assessment, a written declaration, a final request, a final review, and an administration decision. And I'm going to talk about all of these different steps in the conversation with you today. But you can see I'm going to start introducing some of these flowcharts that have been developed in the clinical handbook for you to know where you can go and find more information. So in New South Wales, there have been some support services, voluntary assisted dying support services that have been set up to try to help general practitioners and the community and people working within health districts to provide these services. The New South Wales Voluntary Assisted Dying Care Navigator Service will maintain a central list of coordinating, consulting and administering practitioners. They will provide support, assistance and information to patients, families and practitioners. They're expecting to receive about 25,000 phone calls a year. So, so they're certainly a telephone service that's going to be very, very busy. In some circumstances, the Care Navigator service is going to be able to connect patients seeking access to voluntary assisted dying with practitioners. That's called the Access service. If there are no qualified, eligible, authorised practitioners within an area where a patient may live, they may send out practitioners to be able to provide that service. And they're also going to provide a community of practice for practitioners in New South Wales and support queries from local health districts and other medical teams and healthcare teams. The support services in New South Wales also include the pharmacy service, and the pharmacy service is going to maintain a trained voluntary assisted dying pharmacist workforce. They're going to procure all the substances and materials required for voluntary assisted dying, and they will support accessibility to the substance across all of New South Wales, wherever the patient may be. They will make sure that the substance is accessible and provided to that patient. As we talk today, we're going to be including the Commonwealth Criminal Code in our talk, and it's important we discuss this. The Commonwealth Criminal Code Act of 1995 discusses the offences related to using a carriage service to disseminate or assess suicide-related material. Now, every state across the country that has voluntary assisted dying, the Voluntary Assisted Dying Acts, all clearly state that voluntary assisted dying is not considered to be suicide. However, the Commonwealth Criminal Code still sees it that way. And this means that telehealth, telephone, fax, email, internet, web pages, video conferencing are not ways that we can discuss with people the actual administration of the voluntary assisted dying substance or make a plan for the administration of the voluntary assisted dying substance. So this is a little bit of a challenge. What it does mean for all of you today is that I'm not going to be discussing the substance with you or exactly how the substance is administered. What it means for practitioners in practice is that many aspects of the assessment process and requesting process and decision making of the voluntary assisted dying process must be done face-to-face. And there are certain aspects of it, specifically discussion around the substance, that must not happen via telehealth. And it will be important that if you're doing some aspects of this process on the phone or on audio-visual communication, that you need to advise patients that you can't discuss many aspects of the process that way, and that they will need to come in and have face-to-face, or you'll need to go out to them to have face-to-face conversations about this. So it's a challenge, and I believe that there is some process at the moment to try to overrule this act or get rid of this act. I'm not sure what the exact word is, but I believe that's in process, but it's certainly not the case at the moment. So let's talk about the first request. A first request is a clear and unambiguous request for voluntary assisted dying. It must be made during a medical consultation, and it must be made in person or in accordance with the use of audio-visual communication within the Act. It can be made to any medical practitioner. So that medical practitioner does not need to be an authorised practitioner. It can be a junior medical officer on a ward. It can be someone who's only been practicing for 3 or 4 years, and it can be someone who's not an authorised practitioner. The person who gets the request can refuse or accept the request based on their eligibility to be an authorised practitioner or their availability to be an authorised practitioner. That person must record the first request in the medical record, their decision about whether or not they are able to be to support that person through that. If they refuse the request, whether they've provided information to the patient, and they must notify the Voluntary Assisted Dying Board of the request on a first request form, and that will be uploaded to the New South Wales Voluntary Assisted Dying portal. Now, this, I think, is potentially the most challenging part of the Act for medical practitioners to get their head around. And in the sorry, I'm just having a bit of trouble there. In the clinical practice handbook, there is greater detail. This is the flowchart that's been put here. So let me just talk you through this bit a little bit more. If you are an authorised practitioner and a person comes to you and asks for voluntary assisted dying, and you have the time and availability to accept that request, then you can inform the patient that you've accepted it within 2 business days after receiving that request. You can provide the patient with the first request patient information form that will be on the New South Wales Health website. You record that in the patient's medical record, and you complete the first request form on the Voluntary Assisted Dying portal. If a patient comes to you and asks about voluntary assisted dying and you haven't done the training and you are not eligible to be a practitioner, then you must notify that patient within 2 business days after the request that you're unable to help them. Provide them with the first request patient information within 2 business days of the request. Record in the patient's medical record the first request, the reason that you've had to refuse that request, and whether you've provided the patient with that patient information, and complete the first request form and submit it to the board within 5 days. If someone comes to you and asks for voluntary assisted dying and you're a conscientious objector to voluntary assisted dying, you must immediately tell the patient that you refuse that request. You must still record in the patient's medical record that you've received the first request and the reason that you've refused that, and you complete the first request form and submit it to the board within 5 days. So that's the first request. And I suspect that there'll be some questions about that later, but please pop them in the chat and I'll come back to that as we move through the process. One of the big questions that come up about first requests is about who can make the first request. And as I stated earlier, it's a clear and unambiguous request made by a person with decision-making capacity acting voluntarily. So no enduring guardian can request on someone's behalf, And an advanced care directive, as many of you would know, is only valid after a person loses capacity. And if you don't have capacity, you are therefore ineligible for voluntary assisted dying. So an advanced care directive is not a way of being able to ask for voluntary assisted dying. So that's the first request process for you there. The next step in the process is the coordinating and consulting practitioner assessments. So the job of the coordinating practitioner and the consulting practitioner in this process is to work out, is the person eligible to access voluntary assisted dying? And that's using that eligibility criteria I discussed earlier about having a disease or illness likely to cause death within 6 to 12 months, having residency requirements, being an adult over 18, having decision-making capacity and acting voluntarily. The coordinating and consulting practitioners are able to refer to other medical or health practitioners for opinions, which may include things like trying to work out whether someone, what the prognosis might be for a disease or condition, whether the person has decision-making capacity, whether they're acting voluntarily. Those referrals can be to people such as psychiatrists, or it may be to people such as social workers for capacity assessments, or geriatricians for capacity assessments, or any number of people who are able to do capacity assessments. It's estimated, and we can say from other states, that it's less than 1% of people who actually need referral for decision-making capacity. And that's anecdotal. I don't have specific evidence to back that up for you, but that's what we've heard from other states. But I think one of the more tricky things is prognostication for disease processes, where you may need to refer to, say, an oncologist for a cancer or a neurologist for a neurodegenerative disease. During those coordinating and consulting assessments, if the coordinating practitioner finds the patient to be eligible, they must make sure that the patient's provided with all the information that they need to make a clear and informed decision about voluntary assisted dying, and that they can confirm the understanding and the understanding of the consequences of undertaking voluntary assisted dying of the patient. If the coordinating practitioner finds the person to be eligible, their job is to notify the board and fill out associated paperwork, and then to refer the patient on to the consulting practitioner to do their assessment, who again, if they find the patient to be eligible, is to let the coordinating practitioner know, the patient know, and notify the board. If the person is deemed to be ineligible, by the consulting practitioner, the coordinating practitioner can ask for another consulting practitioner to do another assessment if they believe that the person is actually eligible. Now, I just will note that some of this sounds quite complicated, and this is quite a high level. This is quite high level information I'm giving you. Again, in the handbook, all of this is very detailed. But if you complete the mandatory training, again, you will receive much more detailed information about how this process will work. So, so please forgive me if you want more detail. Again, put your questions in the chat, and I'll try to come back to them if you need to. Once the person has been deemed eligible by a coordinating and consulting practitioner, the next step in the process for the patient is to complete a written declaration. That will be completed on the approved form and given to the coordinating practitioner. The approved form will state that the patient makes the declaration voluntarily, not because of pressure or duress, and they understand the nature and effect of making that decision. It must be signed by the patient in the presence of 2 witnesses. Now, those 2 witnesses cannot be a beneficiary under the will, they cannot be a family member of the patient, and they cannot be the coordinating or consulting practitioner, nor their employee. So, so finding those witnesses might be a bit challenging for some people, and that's something that, that we're all aware of, and we will hope to support patients through that process. If the person's unable to sign because they have no ability to write or to use a pen or whatever it might be, another person's able to sign the document, the written declaration, on the patient's behalf in their presence and the presence of the 2 witnesses. And if it's done with an interpreter, then that person must also be present and able to sign it as a true and correct translation of the written declaration. The next step for the patient is making a final request to the coordinating practitioner. That final request in New South Wales must be made a minimum of 5 days after the first request. Now, 5 days is actually a bit more like 7 days. If we, and my example for you is that if the person requests on the 1st of December, and then day 1 is considered the 2nd of December, and the end of day 5 is considered the 6th of December at midnight, and so day 7 is actually the 7th of December, if that makes sense. So the 5 days is actually a bit longer than that, as per the legal advice we've received in New South Wales. The final request must be made at least 1 day after the consulting assessment is completed. Then, after that final request happens, the coordinating practitioner must review all the reports, the written declaration, and make sure that all of that is in order, and they complete the final review form. And again, the same as at any step throughout this process, there's no obligation for the patient to continue the process at any time. Now, the next step for this process is the administration decision. Now, the administration decision is about is when the patient decides in consultation with or on the advice of the coordinating practitioner whether they will self-administer the substance or have the substance administered by an authorised practitioner. That decision, again, must be clear and unambiguous. It must be made in person, because it's the discussion around how they will actually take the substance. So this is one of the areas that's very clearly defined in the Commonwealth Criminal Code. It must be made verbally or in another way, such as using communication devices. If the person needs an interpreter, they must be in person as well. And that decision, whether you choose self or a practitioner administration, can be revoked at any time. So the two pathways for administration are self-administration, in which the patient must ingest the substance without any assistance. They must, if they choose self-administration, appoint a contact person, and that contact person is allowed under the Act to receive the substance, to possess the substance, to prepare the substance, to supply that prepared substance to the patient, but not to actually assist the patient to ingest it. And the contact person has legal obligations underneath the Act to give any unused substance back to an authorised disposer. And so there are legal consequences for a contact person if they do not follow the law. Practitioner administration is when we have an administering practitioner. Under the New South Wales guidelines, the coordinating practitioner will be the administering practitioner, unless they delegate that job to another person. And the substance will be provided to the administering practitioner, who may only administer that substance to the patient in the presence of a witness if the patient still has decision-making capacity, if the patient is acting voluntarily and not because of pressure or duress, and they still want voluntary assisted dying. Once the person has made that administration decision about how they're going to take the substance, then the coordinating practitioner is able to request a substance authorisation to the New South Wales Voluntary Assisted Dying Board. They must have had done the final review, had made the administration decision, appointed their contact person before the authorisation can occur. The application to the board has no time frame from which the coordinating practitioner needs to do it. However, the timeliness of, as we've seen from Victoria and WA, is that this needs to happen in a timely fashion. And it must be approved by the board unless the board believe that they haven't received all the documents relating to the request and assessment process, or they have some suspicion that the requirements of the Act have not been met. If they refuse the substance authorisation, they will advise the coordinating practitioner within 2 business days of that decision. And if they approve the substance authorisation, they will provide that substance authority as soon as practical, and that'll be available on the Voluntary Assisted Dying portal, hosted by Ministry of Health. Once the authorisation has been provided, then the coordinating practitioner will need to write a prescription. That prescription must occur within 6 months of the prescription writing must occur within 6 months of the substance authorisation from the board, and it will be valid for 6 months from the date that it's written. It will be written on a voluntary assisted dying prescription template, and it will go directly to the New South Wales Voluntary Assisted Dying Pharmacy Service and not to the patient. Before writing the prescription, the patient must be provided in writing the patient information booklet for their chosen administration route. The patient then is responsible for contacting the pharmacy service or the administering practitioner when they are ready to have that prescription filled. So even though the prescription will be sitting with the pharmacy service, it's not automatically filled until the patient asks for it. The Voluntary Assisted Dying Pharmacy Service will only supply after they've authenticated that the prescription is correct and true and accurate and as it should be. And the pharmacy service will deliver it directly to the patient and or their contact person or the administering practitioner, and that will come with further verbal and written information about how they will take that substance. Substance management is a concern certainly within our health district, and I've just given some high-level detail here about what we're looking at for this. For people who are going to self-administer that substance, the person or their contact person will receive that substance by the pharmacy service. It will be in a locked steel box in which the patient has the key. And that substance, the management of that will be up to the patient and their contact person about how they store that within their household, but it must be locked at all times until they're ready to take it. If it's practitioner administration, then the practitioner will receive that substance, and storage for that will be at the discretion of the place of employment or this place where the practitioner practices. In our facilities, and that includes aged care facilities, private facilities, public facilities in our district and in all of New South Wales, that is up to the individual facilities about how they're going to manage people bringing their own substance into the hospitals or aged care facilities or private facilities. The patient, what I would say about this that remains central to this entire process is the patient is entitled to have their legally obtained medication. It must be kept in that locked box at all time. Only that patient and contact person has the key to that box. And our facilities across New South Wales need to make sure that the patient has access to their substance 24 hours a day, and that access cannot be hindered by staff within those facilities. So, as you would imagine, that's quite a challenge. So that's something we're certainly working on within our district about how we're going to be able to manage that in a safe way, so that the patient's access to their substance is not hindered by people that may be looking after the patient, certainly in the self-administration process as well. Now, death certification in New South Wales, the way that after people take this substance, there is a new medical cause of death certificate that has been developed and amended for the Voluntary Assisted Dying Act that will be available at the beginning of November for practitioners to order for their practices, for health facilities to order for their facilities, and we can certainly distribute that information about what the new medical, and Elise might be able to, I know Elise, my colleague, is online. She may be able to pop into the chat, hopefully, some details around that, but you can't order it yet, just so that you know that. But on our on the medical cause of death certificate in New South Wales, there has been an additional box added that states that the medical practitioner knows or believes that the patient has self-administered a voluntary assisted dying substance, and the reason, what it will also state as usual on the medical cause of death certificate is the disease, illness or medical condition which made the person eligible to access voluntary assisted dying. So that's kind of the process. There's a lot more detail in the clinical handbook around death certification and who will do that, but that's something our coordinating practitioners will need to discuss, negotiate and plan for with the patient about who's going to write their death certificates and how that will be managed within community or within facilities. That's something that should be discussed with the coordinating practitioner and their patient. So I'm just going to very briefly highlight a couple of articles that talk about grief and bereavement in voluntary assisted dying from Canadian studies. And basically this is just some information about caregivers and what they thought about medical assistance in dying in Canada. And that is that many caregivers perceived this was a very positive experience because they were given a sense of control, that the patient was able to preserve their dignity and had an end date to their suffering. And most importantly, that patients had a chance to say goodbye to their loved ones and friends in a controlled manner. Other things that they report is that when they compared the deaths of someone who had medical assistance in dying, they found that the final days were not as difficult compared with their experience of other natural deaths at home. And they attributed this to the avoidance of escalating care needs typically required in the terminal phase of people's lives. But ultimately, what we need to remember is that all of these patients who, whether they're having medical assistance in dying or whether they are dying naturally, is that all families need support at end of life, and that the care that people receive before and after voluntary assisted dying and the trust and the relationships that they build with services need to be maintained and established over time. So that's kind of an overview of voluntary assisted dying. And what I would like to do now is talk a little bit about the Hunter New England district as a whole. We're a very large district, and I'm aware that many of you are from different areas who are listening in tonight. But we in Hunter New England Local Health District have been trying to work out how we're going to support the people across our Hunter and New England areas with voluntary assisted dying. So let's talk a little bit about demographics. We have 131,785 kilometres squared that we cover as a district with almost 1 million people. We currently are responsible, that's not the right word, we currently have about 15% of New South Wales deaths occurring in Hunter New England and 14% of New South Wales cancer incidences of cancer occur in Hunter New England. And therefore we know within our district that we have significant workforce challenges, not only for voluntary assisted dying, but for all aspects of care provided to patients across Hunter New England Area Health District. So we've been working very hard over the last 9 months in trying to work out how we can implement this in a safe and effective way across our district. So we have been working on the governance structures that we will implement for voluntary assisted dying, and in Hunter New England, our current executive sponsorship is the Executive Director of Medical Services, Paul Craven, who's our executive sponsor. Our governance structures and our steering committees that we've been working with includes people from all over the district, all multidisciplinary teams and people from our faith-based organisations, and we've also had membership from the Primary Health Network. Paul Craven, our executive sponsor, has started, actually filmed a 3-minute introduction to voluntary assisted dying several months ago that's been available for staff across our district. We did a workforce survey, which I'll share with you in just a moment. We've been doing lots and lots of education. I think we've done, I'm not exactly sure how many, maybe over 50 education sessions. I'm guessing at that just now. We've done some mapping of cancer services across our entire district and where these patients might actually be based and where those touch points for cancer services may be and where people may actually request voluntary assisted dying. We've written a hospital health pathway, and this clearly is of no help to people working in the GP areas, but there is also some work which we'll hear about later from Sandra regarding community health pathways, but there is more work happening in that space. We've developed a model of care and how we will fund and how we will support access to voluntary assisted dying services. And we've also been working on how staff and wellbeing will be managed within our district and supporting those people who are actively involved in this process. So our workforce survey that we did went out to everyone across our district, and some GPs received that as well. That really was talking about support for the introduction of voluntary assisted dying in New South Wales, and you can see we had almost 83% of people were supportive of the introduction of this program. And you can see here that we had quite lots of people who were willing to participate in voluntary assisted dying in terms of referring on to other services to provide general information and also participation in the process. We did a survey. In the survey, we asked people who would be eligible to act as coordinating and consulting practitioners, and you can see that the distribution of that was challenging, especially in our rural and regional areas in the northern part of our district. But in central Newcastle, we had quite a number of practitioners willing to participate, and I'll talk a little bit more about that, but certainly we know from Victoria and WA that the majority of these people are from metro areas, so it may be that's how it's going to look across the district anyway. In terms of the motivators for people to participate and support voluntary assisted dying, the motivators seen across our district were relieving a patient's suffering, respecting the patient's right to choose the time of their death, and supporting the patient's access to a legal medical intervention. And the barriers were really around the fear of the impact emotionally on people themselves, the perceived lack of wellbeing support that people have across our district, and also some concerns about how the workforce would support people participating in this work. We asked staff, those almost 2,500 staff, what support they thought they would need. Largely, you can see that it's continuous professional development and clinical supervision, as well as ensuring that there's some formal peer support arrangements, debriefing, and some external counselling services available for people. So in this district that we live in, with up to 1 million people, these are some of the numbers that we're expecting or thinking might happen. So we are thinking there will be approximately 330 to 440 first requests in our first year, which will equate to up to 160 deaths each year. We have started to work on a centralised service that will act as a support consulting team. We are going to try as much as we possibly can to ensure that all of our processes remain patient-centred at all times, but more importantly, that it's embedded in existing clinical pathways. And we will work very closely and coordinate well with the New South Wales Voluntary Assisted Dying Support Services. We have worked and hopefully, I hope I'm not talking out of line, but got some funding, and we have already started recruiting to these positions within our service. So H&E Hunter New England will provide a voluntary assisted dying service. There has already been recruitment and appointment of a medical director and medical practitioners, staff specialists who will work in this space. We have got some approval for nurse practitioner funding. We have got approval for clinical nurse specialists who will act as care coordinators. We have got approval for some social and emotional and cultural support workers, and we have approval and are in the final processes of appointing an administration officer. So these are funded positions that will be able to do this work across our district. So our ongoing current priorities to get ready for November the 28th is that we are working on a hospital health pathway. We're going to continue to develop the model of care. We are onboarding those positions, and hopefully most people will be ready to start work at the beginning of November. We're fitting out an office space, which is going to be based in Wallsend. We're going to continue to educate people. We have a face-to-face practitioner training day, which will be held in Newcastle on the 4th of November. Now that, if people wish and after today are interested in becoming an authorised practitioner, then you need to register through the New South Wales Voluntary Assisted Dying portal to become an authorised practitioner. They will then review your application to do that. And if you are successful in your application and you fit the eligibility criteria, they will give you the option to attend face-to-face training or online training to become an authorised practitioner. The face-to-face training, as I said, for Newcastle will be based in Newcastle on November the 4th. So if that's something you're interested in, I would suggest that you register as soon as you can so that you can be part of that day. And within Hunter New England, and again, I know that this isn't particularly relevant for the GP world, but we certainly have a communication strategy in which we are trying to ensure that our staff across Hunter New England are aware that voluntary assisted dying will become law and accessible for our patients on November the 28th. So we've developed lots of resources, and there's lots of resources available for you. And there's some of this will not be available to you. I'm thinking my previous Grand Round presentation won't be available to you, but you've just heard this one, so it's the same. And hopefully that provides you with some of the information that you need. If you want further information, you can find lots of information on the New South Wales Health website, which is again is where the Clinical Practice Handbook is going to be stored. You can send any emails that you would like to myself or my colleague Elise on that email address that I've got there for you. And please know that there are many resources available if you find any part of this distressing, or if anything else in your life is distressing, that there are support services in New South Wales that can help you. So I'm going to stop there and perhaps stop sharing my screen. I'm not sure about that, Phoebe, but and see if there are questions that need to be answered. I'm aware that I've got very dark in here and I haven't got the lights on, but I will take any questions and see where we're up to. I don't know if I can see the questions, Phoebe. That might be a challenge.
So I'll read them out to you if that's all right.
Yes, of course.
First of all, I did want to mention that Elise did send through information about the death certificate, and I have put that in the chat function for everyone to see.
Great.
Our first question is about the kind of diseases that people are eligible for voluntary assisted dying. You did mention that there was respiratory diseases, and the question is which ones, like what kind of respiratory?
There is nothing that is the Act does not stipulate what sort of a disease you have to have. What the Act stipulates is that disease, illness or medical condition is likely to cause your death within 6 months or within 12 months. So the majority, as I said, in Victoria and WA, the majority of diseases are malignant cancers. That's 60 to 80% of diseases are malignant cancers that make people eligible, and the next most common is neurodegenerative. However, if we're talking about what sort of diseases you might see in the respiratory space, it might be people with end-stage COPD or idiopathic pulmonary fibrosis. It might be people with other lung diseases that might make them eligible. I guess cystic fibrosis might be one of those things. So there's many different things that might make people eligible. It's not what sort of disease you have, it's whether or not it's likely to cause your death within 6 to 12 months.
Okay, thank you. You were speaking about the 10-year of professional experience required. Is that limited to Australian experience, or does the overseas experience count towards that 10 years as well?
So the 10 years is specifically around the person being a specialist in their area of medicine, or they have been had held general registration and been practicing for 10 years. The overseas trained specialist or the overseas trained medical officer may only be, depending on where they're up to in their training program, may only be eligible to act as an administering practitioner depending on their status. But if they're a specialist, the 10 years is kind of not irrelevant, but you know, you only sort of become a specialist after 10 years of practice, really. So that's that kind of part of the Act. But there are obviously going to be some career medical officers who may have been practicing for 10 years, or other people who might not have completely completed their training who may have been practicing for 10 years.
So this is a whole bunch of questions in one question. So
right.
If you need
Let's
to
start with one bit at a time.
Yes. Just let me know. Has the training been released yet? Is it funded?
Yes, it has. There is no funding to complete the training. That is up to you to do that in your own time. Depending on your familiarity with the Act, it can take you anywhere from 4 to 6 hours, I believe. But that is up to an individual to decide to undertake that training, and people are not funded to complete the training. But once you need to people need to apply through the portal that they wish to become a practitioner. That includes doing some things such as providing your CV, your AFRA number, trying to think what else there was, residency evidence, can't remember what else there was in there.
Do you have to be an administering practitioner if you have done the training?
No.
Has the
you don't
LHD
have to be, you actually don't have to take on any, you can do the training and not take on the coordinating, consulting or administering practitioner role. You only have to accept that role if you have the capacity, the willingness and the ableness to be able to do it for that patient. So if you can't do it because you're going on holidays to Europe for 5 weeks, then you would say no to the patient, even though you might be an authorised practitioner. And you may decide that you're willing to be a coordinating or consulting practitioner, but you don't want to administer the medication. You're allowed to make those decisions about what you do and don't do as part of the Act.
Sure. And has the LHD employed some doctors for voluntary assisted dying?
We certainly have. So we have appointed, none of this has been, none of the names or the final processes of this has not happened, but we certainly requested funding for 2 FTE of medical practitioners, staff specialists who would fulfil that criteria for coordinating and consulting assessments, and those people have been notified, I believe, of that opportunity.
Okay. It is my understanding that palliative care is generally not supportive of voluntary assisted dying. Is this correct? What happens if a patient is having palliative care and during that care decides they want voluntary assisted dying and they are eligible for it?
They are absolutely able to do both. And as I mentioned during my talk, it's actually part of the Act that palliative and end-of-life care options are discussed with the patient. Now, some patients will be receiving palliative care and may be eligible to apply and go through the process of voluntary assisted dying. As I also mentioned, it is not legal for any medical practitioner to withdraw services that they would normally provide to a patient. I wouldn't say that palliative care is not supportive. What I would say is that this is different to palliative care. Palliative care is a specialty area of medicine that works on the relief of impeccable symptom management and support of people with life-limiting disease and improving their quality of life as best as possible. And voluntary assisted dying is one option that people who have a life-limiting disease may be eligible to have. So all of my interactions with palliative care services is that they are not going to hinder any access to voluntary assisted dying, but it's not going to be their responsibility to provide those services within our community. Some palliative care practitioners may wish to, but it's not their responsibility overall.
Are we looking at the request and notification forms to be made suitable for GP software?
The answer to that is no. Well, yes and no, depending on the question. So in terms of the voluntary assisted dying portal first request form that all medical practitioners who receive a clear and unambiguous request for voluntary assisted dying during a medical consultation must complete, that will only be available on the New South Wales Health Voluntary Assisted Dying portal. It will not be available within GP software.
Sure.
Referral to other services will be available via community health pathways, which we'll speak to in a moment, but not the first request form. You will actually need to go into the voluntary assisted dying portal to access that, is my understanding.
Okay. If we need to refer to someone else, can that discussion be done on telehealth? Thinking about sick
Yes.
rural patients, or is this
Absolutely.
not allowed as per the Commonwealth restriction?
So the Commonwealth restriction, which we all have our fingers crossed will be eliminated shortly, but it's still there at the moment. You can have many parts of this assessment process discussion with the patient, as long as you're not talking about how they actually take the substance. So talking to them about their decision-making capacity, talking to them about voluntariness, talking to them about disease, talking to them about the processes of voluntary assisted dying and the steps of it, those things are okay as long as you're not discussing how they take the medication, how they utilize the medication and how they actually do it. So, you know, if you say, I think you need a referral to speak to a psychiatrist, you can say that online, that's fine. If you say, look, I'm unable to help you with voluntary assisted dying, or I think you need to do this and this for voluntary assisted dying, or this is the next step in the process of voluntary assisted, you can do all of that online or via the phone. It's just the actual discussion around the substance. And the advice from Ministry of Health is that you really need, medical practitioners need to be careful that they're not going to breach the Commonwealth Criminal Code, and we need to tell the patients that there's aspects of this that cannot be discussed over the phone, and hopefully this part of the law will change in the not too distant future.
Okay. We're talking about a interpreter before. Does the interpreter need to be a formal interpreter? Because a lot of family often interprets, but this might prove
family are not allowed to interpret, so they must be accredited interpreters. And there's more information. There's a whole section in the clinical practice handbook actually about where to find those interpreters and who they should be, and that they're accredited to be not just interpreters but also translators, because there's not only the verbal aspect of these discussions, but there's also the written declaration aspect. So they must be an authorised translator as well as an authorised interpreter, and not all people with that qualification can do both those things. So so there's two aspects of that that need to be considered. And also, if you're discussing the medication, that needs to be in person, so you need to be able to get the interpreter or translator to the person to be able to do that.
Sure.
And interpreters and translators also have the same rights under the Act to hold conscientious objection.
Sure.
And they also, and I think they also can't be related. I can't remember that bit. I apologise. I think there's some information there about them not being related to the patient.
Mm.
But I can't remember that. I apologise. But it'll be in the handbook.
How is voluntary assisted dying funded, and what is the cost to the patients to access it? Will it be under Medicare?
No, it is not under Medicare. There is no MBS item number for voluntary assisted dying, but there is, the only cost to the patient would be normal charges associated with a consultation, but there is no MBS number. So if you are doing this in a GP practice, not as part of a voluntary assisted dying service, such as the one we have in we're having in Hunter, New England, then there's no funding associated with it. What there is that I failed to mention is, and certainly within Hunter, New England, will be the appointment of, and I think they've been advertising as well across New South Wales, the appointment of zero contract hour VMO positions to be able to do this work, which may be a way that people could become involved in that, so that you're not actually employed particularly on an hourly base, on a contracted basis, but that you can act in those positions, if that makes sense. Sorry, my brain's a bit fuzzy, but there are zero contract hour VMO positions available as well.
Okay. This is a bit of a big question. If a person has a guardianship in place for other issues, and the individual would like to access VAD, but the person with guardianship does not wish for them to access it, what's the process?
So the person must have the capacity to be able to, the person must have the capacity to be able to do that and to understand the implications of that. So if a person's under guardianship, we'd have to know why the person was under guardianship and for what reason. Decision-making capacity is in relation to voluntary assisted dying. So some people may be under guardianship for financial reasons or other reasons, but the decision to access voluntary assisted dying must be the patient's and the patient's alone, and they must be able to understand what voluntary assisted dying is, retain the information go through that process, which is not easy to get through, and understand the implications of that. Another person cannot stand in the way of that. However, there is some allowance under the Act for people to appeal decisions through the Supreme Court for voluntary assisted dying. Again, that is you know, a guardian may decide that they want to do that. There are many scenarios that we can, what if this happens, but what I would say to you is that the law is very clear around the ability to appeal, and the patient must be the person who has decision-making capacity and is acting voluntarily. I hope that answers that question.
Thank you. If a person is ineligible for voluntary assisted dying, do you still have to document them and submit a first request to the board?
If you receive the first request form and it's a clear and unambiguous first request in a medical consultation, yes, you do.
Okay, good. What are the witness requirements when the voluntary assisted dying substance is administered? Can the witness not be a family member, employee, etc.?
So the witness to the administration by a practitioner cannot be an employee or family member of the coordinating, consulting or administering practitioner. So, for example, in a GP practice, it could not be the practice nurse or the wife or partner or family member of the person of the medical practitioner.
Sure. If the patient is deemed ineligible, for example, possible coercion or untreated depression, does it need still to be reported within 5 days?
Yes.
Yes. Will the LHD fund a nurse to be the witness?
So, will they fund the nurse?
Fund the nurse.
The question?
Yes.
So I think my answer to that is no. But there will be nurses within our service, and our nurses may be witnesses if required. But in terms of, I suspect what this question is getting at is if, for example, there's a community nurse who has been helping and they are asked to be a witness, they won't be funded for that, but they are able to do that if it's within their scope of their practice and they understand the ethical and legal obligations of making that, becoming a witness.
I was coming from a more of a rural town standpoint.
Yeah, there is no specific funding for being a witness. No.
Last question. GPs are not used to prognosticating, often for chronic or malignant disease. It may take more than 4 months for a specialist appointment. So how do you think prognostication might be managed well, or how has it been managed in other states?
That's a really great question, which I can't tell you the exact answer, except that we are hoping that we are trying to build within our processes that the prognostication question, and one of the things that we certainly can advise patients to do is when they're having their appointments with their neurologist or their medical oncologist, if this is something that they're asking for, that they ask their practitioner to provide them some sort of letter in writing regarding their prognosis. So that might be one way of going around it. If they're not known to a specialist, which I suspect is going to be the exception rather than the rule, that picking up the phone and asking a specialist to make this, to try to help determine that, or a colleague. We're hoping to have a broad breadth of medical practitioners within our service that will be able to support that, and also we're hoping also to have a broad pool in which to dip to be able to make sure that this happens faster than a 4-monthly, some of the services. It's the same actually for things such as mental health assessments and decision-making capacity. Part of the stuff that we've been working on is trying to ensure that when there are the exceptional circumstances where access to specialist opinion is required, that we have some processes in place to be able to escalate those requests in a timely manner for some of these patients.
Okay, great.
But I don't have all the answers on that, but yeah.
I bet.
Yeah.
I'm just going to throw over to you, Sandra, to talk to us about health pathways.
Thank you so much. I'll just make sure I'm sharing the right screen. Can you see the right screen?
Yes.
So the Health Pathways login? Fantastic. Yes. So for those of you who are new to Health Pathways, and I'm hoping there's not too many of you that are new to Health Pathways, the login for the community site is on the left-hand side of your screen. You can either QR code it or use the URL, and the username and password are there. I'll just go to the, sorry, my mouse is not working. There we are. So this is the home screen of the Community Health Pathways site. But firstly, I just want to say thank you so much, Jeanette, for that incredibly informative presentation. That was fantastic. The Health Pathway has got some brief information to get you started, but we are currently working with Jeanette and the team at the LHD to try and really articulate what those referral endpoints are and what is available to support GPs and other primary care clinicians in this space. The pathway that you're looking for is the voluntary assisted dying pathway, and you can either search for it as VAD or voluntary assisted dying, whichever one that will take you to that pathway. The information that's there is just some brief information to get you going, but it is a state-based pathway that is being run by the Central Coast Health Pathway team, and they are madly working at the moment to update all of that information so that it is live and ready for you on the 28th of November, ready to go. But there are already some things in there that Jeanette was talking about, like the some New South Wales health information and what the current role of GPs is, the portal information that you need to get onto, and the education and training that Jeanette was alluding to. So you can go on there now and have a look. If you're looking for something in particular, one of the little tricks for looking for things on Health Pathways is to click Expand All and then Control F what it is you're looking for. And so, for example, if it's, you know, where do I find out about the portal? You can just pop it in the search bar there and it'll take you to every instance of the portal on the pathway. The only other thing I'd like to point out to you before I sign off is that we do have some new decision-making capacity and consent pathways that might be useful in this space. And we do have a bereavement pathway that we've recently updated and has been looked at by the John Hunter Hospital Bereavement Coordinator. So I will throw back to you, Jeanette and Phoebe, but do definitely watch this space because this pathway will be updated in the next couple of weeks.
Thank you, Sandra. So no other questions have come through, so we can all get on with our evenings. I just wanted to thank Jeanette. Fantastic presentation, really full of information, useful information, and I know that this is a very hot topic at the moment. Thank you, Sandra, for spending your evening with us. Thank you to everyone for your questions. They were really good questions, detailed questions, and precisely why we run education forums like this, so that you can get the information that is going to make a difference for you. Thank you to everyone for spending your evenings with us. I know that it's your dinner time or your not working time, or on bad days still working time, but we really do appreciate it. And a huge shout out to Jeanette, who got home at 2 a.m. this morning and still provided us with nothing but a fantastic education session. So I wanted to thank you all again and have a good night.
Thanks, Phoebe. Thank you.